Okay, good morning again. Okay, so I just would like to show the case that it is actually the diagnosis is not difficult, but the way of treatment, if it's not that at the target point, it's going to be in problem. I got this patient, actually, she is 35-year-old female that came in because of persistent right ear tinnitus, even status post endovascular treatment from the other country outside Thailand. And actually, she is a doctor, and she already known about her diagnosis. And after got treatment, because of her symptom is still, and no, fortunately, that she tried to search me, and at that time, I already published about this disease. So let's see what is going on. Okay, so I try to do the basic first, that to see what gonna find the shunt is in this area. Once that I receive this patient, you can see that there's the core, two pairs of the core, and this is the vertebral angiogram. That it's just look. Everybody know that is the last residual shunt, but where it is, okay. So I just make this point, okay. I think this is here, okay, and from the image, actually from the only imaging, you cannot do that. Know that, right? Okay, let's go to the left side. Okay, so actually, it's go to the same thing, nah? And I point at the same point that where it is. I think it's where it is, but right now it's not that clear, right? So you know that anastomosis is around this area, right? It is a posterior cervical, ascending cervical, occipital, ascending pharyngeal artery, and so forth. Okay, so now I couldn't find the posterior cervical artery, and I got to this one. It is like ascending cervical artery. You can see that here, right? That is the catheter is, and the core, that's core, just right in this artery. But fortunately, it's not total occlusion. Okay, and when you inject here, you see something, huh? Definitely, it residual shunt on the lateral view. This here, where I point at the same point that I can see from the vertebral injection, right? This is the way that we have to find where the residual shunt. So it should be some. This is the ascending cervical artery, right? So it should be something, and the shunt is here. But I cannot go for transarterial without knowing anything else, right? Okay, right occipital artery. See? Again, it's go to, and you can recognize the same vein, right? Definitely, we know that should be there. But how can we get to that supply? Okay. Also include the supraclavicular artery here. You can see that? It go right away around this area into the same shunt. Actually, you know that, right? That VVF, it's only the single shunt. It's a single shunt hole is right there. So the way that I've done is that I go for the win, because I just planned that probably I can go and block that the residual by the vein. Okay, you can notice here, that's right. So the arrow point at the venous catheter, okay, and after inject here, okay, it's from here. I couldn't see quite well because the shunt is a little bit higher above. Okay, the thing that I do is that I do the roadmap from the ascending cervical artery. Okay, the arrow is point at the ascending cervical artery. Okay, here. So definitely, this is the most obvious branch that you can see the supply where this shunt is. Okay, so I put my micro catheter just right in here. It should be somewhere here, but because a significant amount of anastomosis around here, right? So it may be difficult may be difficult to control the definition. So the thing that I do is that I put, because after the for a while, I can put the micro catheter up to the end of the vein, to around there, right? And put a coil down here. And selection from that ascending cervical artery branch, you can see that it's still. So the coil above, it's just distal to the vein. Also, sorry again. Although I know that the point is right here, but the microcatheter cannot go there. The thing that I do is that I decide to go, because we already know that the shunt should be here. The shunt should be around here. So I'm slowly inject glue transvenous, hopefully that it can go to that shunt point. But it's not go that much. After that, it's going down. So I stop there. I stop there and make the control. Okay. So you can see that the residual shunt from the same artery. Okay. The thing that I do next, because everything are already there, and I put the glue transarterial at that point. Okay. This is the AP view, and this is the retro view. Okay, this is how the way. So because we know that the safety margin is quite far, right? And slowly inject until it fills all of the things there. Slowly, you don't have to hurry, because you already have the coil packed in the vein, this proximal and that's distal. And when filling this point, that okay, I think this is the residual posterior cervical artery where the shunt is, that it's supplied to here. And finally, control from ascending cervical. So you can see that it's gone, and you may appreciate all of the anatomy that you need to see, right? So we have to check all the vessel one again. From the vertebral, right vertebral, is still okay. The motion from the left vertebral artery also. And you can appreciate the anterospinal artery also, right? Okay, so let's go to, this is the initial image that I can get from her. That is a pretty main angiogram. You can see here that this is the loop of the vessel. That the posterior. So this is the same one when you inject. So the shunt is there, right? So it's the shunt from the deep cervical artery. And this is the oblique, mean not the good view. Myself, I prefer lateral view. And because of this, so the guys are from her country that put the coil just distal, not the proximal in the deep cervical, and also at the origin also. After do that, you can see that some residual, because this is the anastomosis that go to that artery, right? So you put all this. So all of this coil, this is in the main artery, deep cervical proximal, right? And also proximal is the shunt right here. And try to put something in the ascending cervical artery that, luckily enough, that this artery is not completely occlude, right? And also with this vein. And if occur like this, you cannot claim that this is going to be healed, even though just right after the procedure, or the patient said that the tinnitus is a little bit decreased, but and then it came later. Okay. So this is anatomy that you should all know, right? That this anatomy in here never changed. It still be there. Now, the anastomosis, as Sunita said before already, right? Around with the ascending pharyngeal hospital, around C1, and anastomosis with the ascending cervical, posterior cervical, with the vertebral artery. Okay, so everything be here that you need to do right at the shunt. Okay, so let me briefly to review you for the VVF, But actually, that's the case that I just found that it is not at the vertebral artery. Okay, all of my series that are all at the vertebral artery, not at the posterior cervical artery. Okay, so it's like abnormal connection between the extracranial vertebral artery and the veins that constitute of the vertebral venous plexus. It can cause from the trauma, from arterial cause, and the most important thing is that it is spontaneous. And most of the, I wouldn't say most, the spontaneous can cause from the disease that we know it is the NF1, fibromuscular dysplasia, or the connective tissue disease, okay? The clinical is based on the venous drainage. So if not much venous drainage inside or can cause the reflux into the paravitreal vein, the patient just have the tinnitus and headache, okay, or even mass. Okay, again, the treatment should be right at that point. Okay, so this is just to show that our series already published that it is 14 cases, and so lovely. We found only 9 cases of 14 cases, that is 64%, that is spontaneous, and just only 3 cases of this that found that is associated with the NF1. Okay, and most of the cases that had parallel artery occlusion, whereas intubation that caused by trauma we can preserve. Okay, just to show this is very old cases, but the thing hasn't changed. Already known as NS1, as you can see, came in because of tinnitus and mass. And from here, okay, this is, I have to label, right? Otherwise, it's going to be confused. This is the AP view from the left vertebral artery, okay, and lateral view. So the shunt is away here, and why? A big, if the NF1, usually it's going to have with the large aneurysm, okay, and drain through venous plexus right here. And definitely we do on the other side. And this artery that proves that it is the NF that can cause like this, and I'm going to go to there. And just to know that where that we need to occlude it, right? And similarly, that from the ICA, it caused the PCOM and finally fill that thing. So our goal is to complete occlusion, sacrifice of the left vertebral artery exactly at that point. Okay, the thing that I've done is that go from here, go from the PCOM, because the right vertebral artery, we cannot do because it's so significant tortuosity. Okay, go there, and let's put coil at this point. Distal occlusion, and the rest I do just a little bit glue injection, and this is gone. Nearly similar case now. This 27 years old female came in with a seizure, and you see that a huge aneurysm also. Okay, supply mainly from the left side and something like this. Okay, similar thing. And this just to show that a large huge of the aneurysm, okay? And that time we already have the 3D, and it's nice to demonstrate that we know that where should we be occlude that one. So we go from the left vertebral artery, okay? And you can see that just only glue. Now we use glue, concentrated glue, to occlude the left side, and then we go to the right vert. And we use, in that case, I use only glue. Now this is only glue, and be sure that because it's no any anastomosis around there, right? And it's rather safe. Okay. So after 3 steps of glue injection, everything is okay. Okay, it's gone. 6 months follow-up, everything okay. Another case, NF1, came in because of mass and tinnitus like this, and you appreciate the similar, same thing. Right vert from the left vert, two similar thing, huge drainage vein from the right vert. Okay, it's similar. So at that time, we still have the balloon. So my plan is that we occlusion, proximal occlusion on the left side by using balloon and go from the other side. Just using coil, for control. And after that, inject glue to the microcatheter, and everything is gone. Okay, this is another case. I'm not remember well that it is the MF1 or not in this case. Came in similar thing, but also have a mass effect with the arm weakness. Okay, something like this from the right bird, significant enlarged like this from the. Oh, maybe I missed the side. And actually, this is the left one, and on the right one, it is the hypoplasia. So that's easy. So we just close this one. Just put coil, that proximal for prevent and injected glue, and finally it's gone. And this case, this patient don't have any clinical of the connectivity disease or any one. Came in with the clinical just similar to the CCF dural shunt because of his eye symptom. Okay, so when we do the angiogram, you may not surprise that right that the shunt is at VVF on the left side here, and it go into the vein, paravertebral venous plexus, and after paravertebral venous plexus, it can connection, right? It can go and a connection with the jugular vein via the ACC, and finally is reflux into the pedostal vein and cavernous sinus, and then SOV. So when you know like this, we know that just only here that we need to occlude that. Again, at that time, I still use the balloon. I put the balloon, one balloon, and a second balloon to occlude the artery. But after that, there is some displacement, so some residual, so I need to put some coil in there, but it doesn't matter. So on summary of this, VVF, you know that, right? That it is a single hole there. The main thing is that you have to identify where it is. And if you're not sure, you can play around by inject every artery there. The treatment objective is to complete obliteration at the fistula point. Proximal occlusion is useless, right? Due to significant anastomosis at the neck, as you can see here. So knowledge with understanding of vascular anatomy is the much important key factor of success. You can change according to the time, right? All equipment or embolic agent or anything can be changed, but the concept of treatment should still be the same. Thank you for your attention.